Low backache is an extremely common malady afflicting the human race across the globe, cutting the geographical boundaries, race, culture, etc. 80 to 90% of the human population will suffer from some form of backache, mild or severe, in their lifetime. It is of interest to know the historical background regarding low back pain. Causes of low backache. Common causes: 80%. Back muscle strain and ligament sprain, prolapsed lumbar intervertebral disc, obesity, poor posture, facet joint arthritis, unaccustomed activities. Occupational causes. Uncommon causes, 20%. Congenital causes: scoliosis, spondylolisthesis, spina bifida, spondylolysis, infective conditions, osteomyelitis, tuberculosis, brucellosis, etc. Traumatic causes: vertebral body injuries, posterior arch fracture, muscle sprain, strain. Prolapsed disc. Inflammatory causes: rheumatoid arthritis, ankylosing spondylitis, neoplasms, benign osteoid osteoma, malignant secondaries, multiple myeloma. At metabolic causes: osteoporosis, osteomalacia. Degenerative conditions: osteoarthritis, lumbar spondylosis, referred pain from gynecological diseases, genitourinary diseases, gastrointestinal conditions, etc. Nature of pain: is it sudden, trauma, or gradual? Spondylosis. Was it preceded by weight lifting, sudden bending, etc.? Is there remissions and exacerbations, disc disease, or is it continuous tumors? Is there history of night cries, e.g. TB spine? Is it relieved by rest? Does it radiate to the lower limbs? Etc. Site: is the pain in the middle of the spine or paravertebral muscles? Is it in the dorsalumbar spine, trauma or tumor, or in the lumbar spine, disc disease? Sciatic pain: here pain radiates along the course of the sciatic nerve. See causes for sciatica. Common cause is disc prolapse, Fig. 22.53. Sciatica and its causes. Sciatica is defined as a radiating pain along the course of the sciatic nerve and is felt in the back, buttocks, posterior of the thigh, legs and the foot. It is commonly due to disc prolapse. The other causes are spondylolisthesis, sacroiliac joint arthritis. Affliction of the nerve root by herpes simplex virus can cause radicular pain. Tuberculoma causing cord compression, lymphomas and pelvic malignancy. Ingrowth thickened ligamentum flavum, cysts of the sacral nerve root. Intraspinal neurofibromas and other tumors. Hemorrhage in the ependymoma can cause sudden and gross neurological deficit, mimicking acute disc prolapse. Diabetic neuropathy, etc. Neurogenic claudication: this is a feature of spinal stenosis, see page 300. Neurological symptoms: these consist of paresthesia, muscle weakness, disturbance of sphincters, cauda equina syndrome, etc. Presenting complaints: age: backache is more common in middle-aged and elderly people, usually degenerative. In young adults it is due to trauma, and in children it is usually due to organic lesions. Sex: osteoporosis, rheumatoid arthritis, etc. are more common in females. Ankylosing spondylitis, trauma, secondary, etc. are more common in males. Occupation: people with sedentary jobs and heavy manual laborers are frequently prone for backache. Pain: over 90% of the patients complain of pain in the back. Other complaints: there may be history of stiffness, pain in other joints, e.g. rheumatoid arthritis, constitutional symptoms, e.g. tuberculosis, malignancy, etc. genitourinary complaints, etc. Physical signs: stance and gait: does the patient stand with a normal stance or has deformities like scoliosis, kyphosis, lordosis or pelvic tilt? Is the gait normal or altered? Spasm: this is seen in acute painful conditions of the spine. The patient complains of pain in the paravertebral muscles and painful restriction of all the spine movements. Movements: there may be restriction of the spine movements due to the organic lesions affecting the back. Swelling due to cold abscesses may be present. Tenderness: it may be present over the spinous process, in between the spinous processes, over muscles, ligaments, facet joints, etc. Neurological examination: this consists of examinations of the various dermatomes for sensations, myotomes for muscle power and reflexes, see page 362. SLRT and tension signs. This is to know the effects of disc lapse on the sciatic nerve. The tests are described on see page 362. Pro. Other examinations. Other examinations include examinations of the adjacent joints, peripheral pulses, abdominal, rectal or pervaginal examinations. Investigations. Blood tests. These are useful in detecting metabolic, hormonal, infective and malignant conditions. Radiology. Routine plane radiographs of the lumbar spine are advised. Both anterior, posterior and lateral views are usually required. Oblique views are helpful in detecting the fracture of pars. Though X-rays are not very helpful in detecting the disc prolapse, it is of value in diagnosing metabolic, degenerative, inflammatory, malignant conditions affecting the spine. Myelography. This procedure is not routinely used anymore because of its complications. However, it has a role in demonstrating blocks due to disc prolapse. CT scan. It is a non-invasive approach and helps to identify the bone and soft tissue problems with greater accuracy. MRI scan. This is the gold standard in the investigations of the spine. It is non-invasive and is better than CT scan in diagnosing the bone and soft tissue problems around the spine. However, its high cost is prohibitive and is available only in major cities and centers. Treatment plan of backache. Summary. Conservative absolute bed rest traction, NSAIDs, epidural steroids, belts for subacute and chronic cases, long-acting steroids plus local anesthetics. Reduces dependence on narcotics. Effect lasts for 3 weeks. Surgery done in proper indications. Open or microscopic lumbar discectomy. Chemonucleolysis. Same indications as for surgery. Limited only to lumbar spine. Drug used as chimopapain. Physiotherapy. Recurrence. Active and passive physiotherapy. Flexion or extension exercises. Back education. Prevention. Proper postural habits. Back exercises. Avoid all sports.